Base. So a lot of the stuff that we talk about today, Anna, I think you probably agree with me, in terms of the research that's available there on transgender care, we do have to look at kind of global the global research base, just because there isn't enough out there. That if we started just looking at the UK, we would be looking at a very, very small amount of data. So we do look at global statistics and things like that. So just because it gives us a much better picture of kind of what's going on for everybody.
I think that's definitely been like one of the interesting things whilst we've been putting together the seminar, is looking at international studies and considering different aspects of healthcare around the world and how those are impacting health trajectories.
Absolutely, because I know, certainly in America, where there's the insurance aspect of care and people being able to access
Canada as well.
and Canada as well. So we're very lucky over here. We have the NHS that comes with its own set of problems and challenges, but certainly for people in America, there's that additional factor as well. So brilliant. So we've got another minute or so, and then I'm going to pass over to Rhiannon to do some introductions. So somebody just asking me for the link, so I'm just going to pop in and get that sorted.
Admin.
Always doing a bit of admin.
So tell us a little bit about why you joined us today. In the chat,
not you, Anna. You're here because
we know why you're here, Anna.
Would it be okay with you all if I took a screenshot to share on Instagram?
Yeah, and just to reply to that comment about the Jing. So I studied originally with Jing for my advanced clinical. So yeah, very familiar with the Jing Institute.
Yeah, lovely. But yeah, absolutely. Steph, feel free to take photos and things like that. I always think it's so important for practitioners to share that you are doing this kind of training, because even if you don't think that you're treating LGBTQ plus patients, if you don't think that you're treating any transgender people, you probably are. And also bear in mind that, we have allies. So we have people like my parents, for example, who love to see when people are doing LGBTQ plus inclusive training, because it matters to them, because it matters to me. So, it's a really lovely thing for your patients to see you doing. So lovely. Right. So,
okay.
Let's do it.
Chat across.
Yeah. Brilliant.
Oh, just starting year 3. Good luck.
Yay. Straight to year 3. Brilliant. Right. Well, let's get started, shall we?
Great. Welcome to the hottest party on Zoom today, and it's COVID safe. Yay! While we wait for just a few more people to join us, because I know that we've got over 200 people joining us, I'd just like to briefly introduce myself. My name is Rhiannon. My pronouns are she and her. And on behalf of everyone here, Anna, Philippa, and myself, we are so excited to welcome everyone to this webinar on the 3 main myths of LGBTQ plus healthcare. So welcome, and thank you very much, because I know that your time is very precious and I really appreciate it. And I know we've got so much to do and talk about today, so I'm going to pass on pretty quickly over to Philippa, but I just want to tell you a little bit about Oakley Coaching. We are the leaders in communication in healthcare, and we provide training and coaching for healthcare clinicians. And we also have 2 courses on this LGBTQ plus healthcare, and it's one for clinicians and one for non-clinical staff in your healthcare spaces. So without further ado, Philippa, my wife.
Lovely. Right, Rhiannon's going to shoot off screen now so that she can be in the chat and see what's going on. So just to let you all know, any questions that you do have, please pop them into the chat. We will try to get to them as much as we possibly can, but we will make sure that you have our contact details afterwards. We do also have our private practitioners Facebook group, which is a safe space. Anna's in there as well as Rhiannon and myself. That's a really safe and affirming place if you've got any questions about this, because I think what we're trying to do with the training that we're providing with seminars like this, I'm sure Anna would agree, is that we're trying to empower people to feel confident in having these conversations and feel confident in the care that you're providing to your LGBTQ plus patients. So what I would like to say, just as a little trigger warning, which I do think is important to touch upon, is that when we are talking about this topic, it's a highly emotive topic for many people. The seminar may also involve discussing transphobia, homophobia, trauma, self-harm, and suicidal ideation and or suicide attempts. For anybody who's affected by these issues, and I mean this very seriously, there is additional support that's available to you. We have links that are available to you. And just as a side note, I think it's really, really important that we're able to signpost our patients and any service users to those resources as well. I think that's something that we cannot underestimate how important that is. Also, just to be familiar with some of the terminology that we use in this talk, the main two terms that you might hear, LGBTQ+, we use that as a term to denote anybody lesbian, gay, bisexual, transgender, and questioning is what the Q tends to stand for. So we use that term. You might hear people use LGBT or LGBTQIA. The problem with the acronym is that it tends to, there's always someone who will be excluded from that, but that's what we use that term to mean, is that all sexual minorities. We also use the term transgender in this course, and again, this is an umbrella term for anybody who falls within that bracket. And we use the term cisgender to denote someone who was born into a body that matches their sex assigned at birth. So you know, a man who identifies as a man or a woman who identifies as a woman would be classed as cisgender. So that's really, really important. So I will just move on to our introduction slide, if I may. So to introduce myself before we pop over to Anna, my name is Philippa, my pronouns are she and her. I'm a qualified chiropractor and I'm a co-director of Oakley Coaching alongside my wife Rhiannon. We have an extensive background in coaching and mentoring with both the NHS Leadership Academy and in private practice. I'm a professional member of the European Mentoring and Coaching Council. And very recently, I started a role with the LGBT Consortium where I'm going to be supporting NHS trusts who are working to achieve their Rainbow Badges programme. So that's very, very exciting. And it's so new that I haven't even put it on my biography. So there we go. And now I'm really delighted to introduce you to the co-author of our course, which is Anna. So Anna, over to you.
Yep, so I'm Anna, my pronouns are she, her, they, them, and I'm an LGBTQ specialist massage therapist. I've been practicing for about 4 years. I'm shortly about to become an advanced clinical massage therapist. And I run my practice in Brighton with easily 90% of my patients and clients being transgender and non-binary. Having so much experience working with that specific group of people, I've ended up becoming a specialist within my field. I've contributed to academic textbooks and have worked with large organisations on inclusivity for trans people such as Lush, LGBT Switchboard, Mind Out, and most recently became Inclusive Therapist of the Year, which was a massive, massive honour. As Philippa says, we wrote the course together, and yeah, we really pulled together our specialisms. So let's jump into it. If you're ready, Philippa, let's talk about our work together and how we got to a point of writing this mega seminar. So we came together to pull together our working experiences, and we ended up writing a course together for manual therapists. To the best of our knowledge, it is the world's first course which specialises in LGBTQ healthcare for those practitioners. And what we found was that we were working with LGBTQ people within our clinics, and we were recognising patterns of specific healthcare needs which were being overlooked by other professionals. And then by making very, very small adaptations to the work we were doing, we were able to achieve really great results. We were seeing a lot of transgender clients experiencing high levels of physical pain due to gender dysphoria, mental health issues, surgeries, hormones, but they felt unsafe to go to other practitioners to share that information about what was happening with their body because they were scared of judgment, scared of discrimination, just scared of a lack of awareness. These patients were often breaking down crying in our clinic because it was the first time they felt seen and respected by a healthcare professional. And for us as members of the LGBTQ community, we felt that we were in a unique position of having the professional expertise to be able to put together a course and to help other practitioners understand what we understood. But as LGBTQ people, we felt we had the empathy that was there as well. We understood very, very personally how important this topic was. So writing the course in itself was an incredibly cathartic and empowering experience. There was definitely times when we would be saddened by some of the stuff we were reading about our community in terms of how we access healthcare. But there was also times that we found things that were empowering and encouraging. And we explored such a wide range of topics. We looked at the prevalence of trauma within LGBTQ people, how this impacts chronic health, both physically and emotionally in later life. And we looked at the physical and mental impacts of gender dysphoria. We're going to talk a bit today about what is gender dysphoria, but in a nutshell, it is the pathology which is experienced by transgender people where they feel that disconnect with their body and their gender. And we looked at the anatomical differences brought about through hormone treatments and surgeries. But one of the issues that we kept coming back to every time we looked at a new clinical study was that despite there being this clinical awareness, LGBTQ people were reporting really negative experiences of healthcare, whereby their GPs, their physiotherapists, their osteopaths, everyone that they were seeing within that health context were just lacking in basic awareness of these issues. This was mirrored in a lot of the statistics we found, and we want to share that we read that 2 in 5 transgender people reported healthcare staff lacked an understanding of trans-specific needs. We're going to talk a bit today about what is a trans-specific health need, but 2 in 5, that's nearly half. All of it highlighted one very specific issue, and that was just a general lack of awareness amongst healthcare professionals as to the specific health needs of the community. So we wrote our course and we set out to change that. And what we saw was there was all this data and all these studies that very clearly evidenced an inequality to healthcare for the LGBTQ community, but it wasn't getting the attention it needed. And we really wanted to try and shine a spotlight on it so that other healthcare practitioners could understand how it was affecting the health trajectories of LGBTQ people, particularly those who were transgender. We were also aware that NHS trusts have a legal obligation to reduce healthcare inequalities for those with protected characteristics. Being lesbian, gay, bisexual, or transgender, these are all protected characteristics. And what we were seeing was that although we had an overwhelmingly positive response to our course, we were seeing examples where people would just refuse to acknowledge that LGBTQ people had inequality to healthcare, again, despite this being something which is very well documented and researched. And it left us with this truth that in order to deliver this course and to change the health trajectories for the community, we have to fight the reluctance in some people to recognise the needs of this community. And to do that, we must dismantle stigma. And that's how we arrived here. So if we just move on to that next slide. Let's talk about where this stigma comes from and why this stigma fueled myth. We wanted to share these pictures. So these are 3 of my patients, and I always find it really startling when people tell me that trans bodies are no different to other people's bodies, because these people are very visibly different to other people's bodies. They've had surgeries that don't exist within any other community. Something that's really important to me is laughter and positivity within my clinic. We have Ray in the middle, one of my transmasculine patients, smiling proudly with his body. And for me, that is one of the clearest memories I have of my practices. When we encounter this comment from healthcare professionals, and we started to see this coming up, and although we were having a mostly positive response to the course, we were getting this comment that people were saying that LGBTQ people's bodies are the same as everyone else's. And you'd have professionals who were able to recognize that when a patient has arthritis or mental health issues, we need to make adaptations to hold that concern and support that person and that patient. There was a disconnect. They couldn't recognize how someone being LGBTQ or specifically transgender meant that they too would require specialist treatment. We also started to notice that there was a lot of studies, if we look at pain perception and pain levels when people have trauma. We're going to talk about trauma in more depth in a bit, but we became aware of studies into veterans, and when people have trauma, their sensitivity to pain and their experience of pain is altered. And by looking at studies into veterans, so not even necessarily LGBTQ veterans, just veterans in general, we were able to start piecing together studies and making hypotheses, is that a word? Making hypotheses about the experience of pain and the differences within LGBTQ bodies.
This is really important just to touch on what Anna's saying. talk about PTSD in veterans, we talk about looking at PTSD in firefighters. These statistics are well known, they're well established, and what we've done is basically look at the experience of what it means to be an LGBTQ plus person and draw hypothetical conclusions based on sensible research, that's well established research, and say, well, hey, actually, maybe there's something more to this that we need to look into.
Yeah, absolutely. So despite everything we knew about biopsychosocial models in healthcare, and we're going to talk about what is biopsychosocial in a moment, we saw this disconnect, and seeing how LGBTQ people's health, and in particular that of transgender people, was almost being waved away and dehumanized was alarming. We found that 23% of LGBTQ people have at one time witnessed anti-LGBTQ remarks by healthcare staff. And this seemed to be being mirrored by some of the comments we were reading. So we started to see common denominators which were preventing clinicians from engaging with LGBTQ healthcare. And one of the most common ones that we got was, but I treat everyone with the same great care. We're not saying that people aren't treating people with great care, but what we are saying is that it's 2022, and saying that I treat everyone with the same care is the medical version of live, love, laugh. We don't treat everyone with the same great care because not everyone has the same body. And this is very much what it means when we talk about the biopsychosocial healthcare model. One of the things we're going to use to illustrate that, just moving on to that next slide, is this very famous illustration about equality versus equity. Now, what this illustration evidences to us is that actually, if we treat everyone the same, we don't actually achieve equality. We don't actually achieve equality at all. In order to achieve equality and equity, we actually have to look at individuals' needs and give them what they need, not what we perceive is equality. Evidence proves that providing equal or the same care when the patient has pre-existing disadvantage doesn't level the playing field. It actually perpetuates further inequality because it fails to address the actual issue. And treating everyone the same does not actually recognise the individual's health needs or recognise how an entire demographic of people can have shared experiences of health issues as well. It's the opposite. It looks the other way in the face of science, and that feels like a very dangerous place to be in healthcare.
One of the things that we've consistently found when we've been writing this course and when we've been doing this in consultation with the LGBTQ plus community is that there are many LGBTQ plus service users and patients that we're caring for who specifically would not seek care if they weren't being cared for by a practitioner like myself, like Anna, who has LGBTQ plus awareness. That's for a myriad of reasons, whether it's safety, whether it's personal preference. A lot of them are saying, if I'm not treated by a patient who understands my health needs, I'm going to spend a lot of my time having to explain myself, having to explain who I am to them. And that can be really disheartening for them as a patient. So that's why the importance of recognizing the difference between equal care and equitable care. And that's why this slide is so helpful to illustrate that.
Yeah, definitely. And what we're finding is that when we're working with healthcare practitioners who can't recognize this and don't recognize the issues faced by LGBTQ people in terms of their healthcare, it's actually akin to looking the other way, and we're starting to get into a territory of choosing who does and doesn't deserve appropriate healthcare. And again, that feels alarming, and that feels like it's dehumanizing. As manual therapists, and I think this goes for everyone working in different types of healthcare, but for Philippa and I coming at this from healthcare practices whereby touch is a very active part of what we do, we believe in the power of touch from one human to another, and we believe that if you work in this field, you hopefully do too, and that this extends to all humans. We feel that if people knew LGBTQ bodies the way that we know LGBTQ bodies within our clinics and within our professional experience, they would recognize the need for change and they would adapt. If they sat in my clinic and they saw one of the many trans women that comes to me and cries because it's the first time that they feel respected for who they are and they feel like they're being treated with dignity, if you saw that, you'd feel differently. And if you sat in my clinic and you were there the day that an elderly gay man with HIV apologized to me for me having to touch his body because of the stigma of HIV left over from the AIDS pandemic in the 80s in gay men, you'd feel differently. And if you sat in my clinic the moment a trans man with costochondritis developed through years of anxiety, of negative experiences of healthcare, and you were there the moment he took that first deep breath that did not hurt his body for the first time, you would feel differently. Philippa is going to talk a little bit more just about patients with HIV, because you had quite a poignant anecdote about a patient you treated as well.
Yeah, absolutely. It's something I think when you're in this field and when you're caring for these people, you never forget these patients. And I remember a chap coming in to see me who was physically shaking to the point that he could hardly say his own name. He was that frightened. And the look of relief and acceptance and delight when I said to him, of course, being HIV positive doesn't change how I treat you. Of course, I can still use dry needling. You know, when we look at the statistics of the likelihood of a practitioner contracting HIV through using dry needling, through using acupuncture, we're talking 1 in 100 globally ever. I think there's been 5 cases in the UK and none in the last 20 years. There is so much stigma that surrounds the care of these patients. And it is a moment that you never forget when you can treat a patient with the healthcare that they need in an affirming way that acknowledges them for who they are, and the experience of them must be so massively empowering.
And we're going to get into it today about the key differences in LGBTQ people's bodies and what we need to do to halt that. But just to flag up the things that we already know to be the case from research, from clinical studies, so these are well-established healthcare facts, was that LGBTQ people are more likely to experience trauma, they're more likely to develop chronic and physical mental health issues and to experience more advanced variations of pathologies. So for example, that's when sciatica develops into equus quadra, which can be potentially life-threatening. And of all these statistics we're going to look at today, I really want us to flag and hold in mind that in every single one of these statistics, the statistics were worse for LGBTQ people of colour because of the inequality and the already well-researched lack of access to healthcare, which is already affecting them. These key inequalities are exacerbated by a lack of access to healthcare, a lack of training amongst medical staff on how to work with people who've had hormone treatments for gender surgeries, and a high level of negative experience of healthcare due to LGBTQ identity. And all of these experiences, they come together within the community and people talk about their experiences of healthcare, and it creates this self-fulfilling myth whereby LGBTQ people are scared to approach for healthcare. And we're going to talk about how that is a deadly combination, which is really affecting the life expectancy within our community. The inequality of healthcare that LGBTQ people experience is an issue which is fueled by stigma. And when we were writing this course and we started to see those negative comments occasionally starting to trickle through, we realized that it's not enough to educate and train. We have to actively break down these myths which fuel stigma so as to provide adequate healthcare. So that's what we're going to do today. We're going to look at 3 key myths. We're going to dismantle them, we're going to evidence why they're false, and we're going to look at what is the truth about LGBTQ bodies. So let's jump into the first one, and yeah, let's do equal healthcare. Go back. Perfect. So myth 1, LGBTQ people's bodies are just the same as ours. They don't need specific healthcare. If I had £1 for the time every time I've read this comment in response to trans healthcare, I'd be very rich. I'd like us just to start by taking LGBTQ people out of it and just changing that statement to people's bodies are just the same as ours. They don't need specific healthcare. I hope everyone can hear how ludicrous that just sounded, because that's not how we work in healthcare. It's a reductive approach to healthcare, and it's one that we've already kind of done away with. In healthcare, we use something called the biopsychosocial healthcare model, and if it's not something you're familiar with, I can just simplify it down in it takes into account your intersectionality and recognizes that your experiences based on your biological factors, your psychological factors, and your sociological factors can be different to someone else's, and that those experiences actually have a profound effect on our health trajectories for the rest of our life. And modern healthcare already recognizes that people's bodies are different and it adapts healthcare accordingly. On your screen at the moment, there is just a few pointers that we've just put in that evidence how the biopsychosocial model impacts LGBTQ people specifically. So talking about things like suicide ideation, we're talking about access to healthcare, we're talking about low levels of oxytocin. And hopefully what you can see from that is we can evidence that in every single sphere of the biopsychosocial healthcare model. And that's a really, really important point. Where we're going to start with this is we're going to start with trauma. I want to talk about the prevalence of trauma in LGBTQ people. And the reason that I want to start here is because I want us to understand the tragic fact for the LGBTQ community is that trauma is their primary pathology. And everything we do with that community has to be seen through that lens. That trauma starts in childhood, and statistically, we know that it is not only trauma that is more likely within the community. It's not just that childhood trauma. We know of the prevalence of sexual trauma as well. We have studies currently which recognize that growing up LGBTQ and the experience of othering, so that's when you start to recognize you're different from others and you start to recognize you're being discriminated against, creates the same neurological impact as childhood trauma. There is also further studies which are now evidencing it is not just it creates the same impact as trauma, it is trauma. So what I want us to remember when we're talking about LGBTQ people is we are talking about people with trauma, okay? I mentioned sexual trauma. That's another very high statistic for trauma within the queer community. For example, we know that nearly 50% of transgender people have experienced sexual trauma. So that's assault and rape. That's nearly half, nearly half. Lesbians are also a very close group, not far behind, and they're just under 50% as well. It is nearly double the statistic for someone who is heterosexual or cisgender. So again, that's large numbers of this community living with trauma. Now, we already know from studies into trauma that when you have trauma, it increases the chances of chronic mental and physical health later in life in nearly all areas. So cardiovascular issues, they increase in likelihood, blood clots, chronic pain conditions such as fibromyalgia, endometriosis. These are statistically more likely with trauma. And we also know autoimmune disorders are more prevalent in people who have trauma. One of the key reasons this happens, and you know what, there's an entire seminar on this topic in itself, but trauma reduces a chemical in your body called oxytocin, and over time this starts to reduce down the success rate of your immune system. It decreases emotional resilience and it increases the tension levels in your body's musculoskeletal systems. If anyone's ever had a really traumatic and stressful day and you felt your shoulders come up and not go back down, that was your oxytocin levels dropping, okay? And this is something that is very, very well documented. The prevalence of trauma within the LGBTQ community, it not only gives us serious thought about, am I working in a way which is inclusive to LGBTQ people, but am I working in a trauma-informed lens? And am I taking the time to consider if my touch as a healthcare practitioner is going to make someone feel safe, or am I about to make them feel traumatized and stressed? We know from studies that 38% of transgender people have had a negative experience of healthcare due to their gender identity. We also know studies which evidence that exposure to discrimination exacerbates symptoms of PTSD in transgender patients. Now, this leaves us with the uncomfortable truth, and that whilst we can't go into that 38% and know how many of them specifically have trauma, we know that over 50% of the transgender community is living with trauma. So law of averages tells us that it is fairly likely that that 38% who've had that negative experience had trauma. And then if we couple that with the studies, the evidence that discrimination exacerbates symptoms of trauma and PTSD in transgender patients, we arrive at this uncomfortable truth that these differences result in poorer clinical outcomes for this group and have the knock-on effect of perpetuating health inequalities for LGBTQ people, simply due to our failure to recognise the role of trauma within the LGBTQ community and how that affects health trajectories.
So although we're talking today and we've been talking about trauma as the foundation for many of the concerns when we're providing care to LGBTQ plus people, we also want to talk about some of the practical differences that we see when we are treating LGBTQ plus people's bodies. Now, Anna has mentioned gender dysphoria, which is the emotional upset that you can feel when your body does not match the way that you feel inside. And this is something that we see in a lot of transgender people. And in fact, these symptoms can be so severe that they lead to people attempting suicide, committing suicide. 89% of transgender children experience suicidal thoughts or suicidal ideation 41% of transgender children have attempted suicide. That literally, it makes the hairs on the back of my neck stand up, and almost half of transgender children are attempting suicide. The common denominator in all of this is trauma and the trigger, and it raises the questions of how we provide care for these people. Now, due to the intensity of some of the symptoms that people feel when they're experiencing gender dysphoria, some transgender people, some people who are gender non-conforming or gender non-binary, they tend to practices like binding or tucking. So binding is the use of effectively a corset or a very tight sports bra type material to reduce the appearance of the chest tissue. Tucking is when they are tucking up the penis and the testicles to provide a smoother appearance for their genital area. Now, we know that practically somebody who is wearing a very tight, restrictive item of clothing around their thoracic spine will experience symptoms akin to thoracic dysfunction. So they will experience tension in that area, they will experience restriction in their thoracic spine, in their rib movements, they will experience a lot of tightness in the accessory muscles, they might have itching, rashes, acne, because they're not practicing hygienic practices because they're wearing it for such a long period of time. Now, we know that 52% of transgender people are taking part in daily binding, and 97% of those who bind had at least one negative side effect from the practice. So what we need to think about when we're thinking about trauma and LGBTQ plus people's bodies is there upper back pain because they have upper back pain, or is it related to the practice of binding? Now, in a further study where we look at musculoskeletal conditions in transgender people, of the almost 90% of those who were experiencing an adverse musculoskeletal or neurological symptom as a result of the binding, only 14% of those people were able to access appropriate healthcare relating to the issue. So if you've only got 14% of people who are able to access healthcare, that is a huge chunk of people who are unable to receive appropriate care within an appropriate time frame. What we know about persistent pain, as an example, is if we're in persistent pain for longer than a period of 6 weeks, it creates neuroplastic changes in our brain. It changes the way that we process pain. It changes our ability to withstand pain. It changes our coping mechanisms. That in turn perpetuates the issue further. So you are then dealing with people who not only have pre-existing trauma, but they have an increased likelihood of developing further problems. When we are caring for LGBTQ plus people and we don't consider these factors, when we don't hold this in mind, we run the risk of providing clinically inaccurate care. Now, also, from a practitioner perspective, in terms of specific healthcare as a practitioner, when a person is undergoing hormone therapy as part of their transitioning, they often use, if they're a transmasculine patient, they use testosterone gel. Now, one of the most common places to apply testosterone gel is on the back of the shoulder, the upper arm, or sometimes on the abdomen. As a practitioner, you need to be aware of this in case you then touch that area. Now, personal story, but quite recently, we went through IVF to have my daughter, and that obviously involves a lot of hormone therapies. For myself as a practitioner, if I had inadvertently, during the course of my IVF treatment, become exposed to testosterone through touching a transgender person's shoulder or upper back and not being aware that they recently applied testosterone gel to that area, that could have a potentially catastrophic impact, not only on the IVF, but also if I was not going through IVF, the exposure to a massive dose of testosterone, there's a safeguarding concern for practitioners as well. So we really, really, really do need to be aware of these issues. So we're going to move on to myth number 2 now. So the differentials for LGBTQ plus patients will be exactly the same for cisgender patients. And again, this is another one. I can see Anna with a vague smile there, because it's one of the where people go, how on earth are the differentials different? Now, we have already explored how the body can be altered by trauma, how gender dysphoria can create different pathologies within LGBTQ plus people. We also need to consider something which is frequently overlooked, which is our reference ranges. So we know, for example, that serum CK, so creatine kinase, those levels are based generally, we have what's an acceptable level based on whether somebody is male, female, their activity levels, and race and ethnicity can come into it as well. So there are different levels that we look at. But for a trans male on hormone therapies, we might need to look at the reference range for a male patient rather than a female. So I should say that a transmasculine patient is somebody who was assigned female at birth, but their gender identity is now that of male. So at what point do we stop looking at the normal reference ranges for a female patient and start looking at what would be a normal reference range in a male patient? There is no guidance, there are no guidelines in existence that we are aware of that tell us when that point would happen. The question is, how long do they need to be on their hormone therapies for? How long do they need to be at a stable level of their hormone therapies before we can safely say we need to look at different levels and where the cutoff is? So this is just one example of recognizing the importance and the importance of the differentials for pathologies which could only occur in a patient's body due to their sex assigned at birth. So for example, if I had a transmasculine patient who presented to me with lower back pain, and they had retained their cervix and retained their uterus, as many of them do, and I do not consider something like endometriosis in my differentials, that could have a significant impact on clinical information, on losing clinical information, and have a significant impact on their plan of management. So that is one very real example of how the differentials differ for LGBTQ plus patients.
And when we're talking about CK levels, so CK levels is a very, very clear-cut example, but there are multiple examples of the ways in which diagnostic differentials are actually different for LGBTQ people. For example, if we consider trans women who are on hormone treatment, so that's whereby they're taking estrogen, there are now emerging studies which evidence when the estrogen levels come up in the body and the testosterone levels come down, this actually has an impact on the bone mass index, and this increases the chance of spinal deviations such as kyphosis, scoliosis, and also osteoporosis. Again, if this is information we are not aware of when we're treating patients, the treatments that we're giving could not only be significantly reduced in success rate, but we could actually physically hurt someone by not taking into account that mobility that's going to be in their spine. When we talk about diagnostic differentials, I also just want us to kind of turn our attention to talking about gender affirming surgeries, okay? Now, we're not going to get into too many specific details about these surgeries because these are incredibly invasive and they are whole topics in themselves, explaining how we construct penises, how we construct vaginas. These are very, very complicated surgical procedures. But what I do want us to do is I want us to consider how these surgeries actually impact diagnostic differentials in transgender patients. So for example, I'd like to talk about phalloplasty. A phalloplasty is the creation of the penis. Now, when a transmasculine patient is having a phalloplasty, a skin graft must be taken. That skin graft is either going to come from the leg, the arm, or it's going to come from the waist, around about the latissimus dorsi area. Now, that skin graft is now, that site of the skin graft is going to be a site of great sensitivity. It's going to be reduced range of motion, and it's also going to have a knock-on effect on your patient's ability to tell you what symptoms they're feeling. So let's just go with two examples of nerve-related pathology whereby this would now become an issue. Let's talk about thoracic outlet syndrome. One of the key things you're going to be asking a patient if you suspect thoracic outlet syndrome is sensation in their arm. If they've had a phalloplasty and the skin graft came from their lower arm, their sensitivity in that area is altered already. So they may not be able to tell you what they can and cannot feel. Thoracic outlet syndrome, when it develops into its most aggressive forms, can result in people having ribs removed to fix the pathology. So that's how serious a condition we're talking there. Another example, another nerve-related pathology, sciatica. Again, sciatica is going to be requiring you to check in with your patient about their level of sensation in their leg. If they have had a phalloplasty and the skin graft has come from the anterior lateral side of their thigh, they are not going to be able to tell you if they can feel the sciatic nerve or not. It is a site of physical and emotional trauma. Sciatica, when left, when not addressed, can develop into cauda equina, which is a potentially fatal pathology. Again, these are big, big issues to be dealing with, and running the risk of running the risk of not spotting these things because you're stuck in a headspace that the differentials are exactly the same. If we also talk about mastectomies, so that's when transmasculine people have top surgery to flatten the chest tissue. These increase the chances of thoracic outlet syndromes. Anything in the brachial plexus, which is an area up here, we know compression to pectoralis minor and the brachial plexus increases the chances of thoracic outlet. If they've been binding and then they have the mastectomy in the top surgery, they're more likely to be developing thoracic outlet syndrome. if we're looking at someone's body and thinking we don't need to consider these things because the differentials are exactly the same, we could potentially miss the diagnostic differentials for life-altering pathologies. And as in previous examples that we've just looked at, what we're seeing is a complete lack of clear understanding amongst healthcare professionals as to how anatomical differences and health issues interact with being LGBTQ. And another one that we're just going to touch on really, really briefly, and again, it's a big one, and we're picking these deliberately to really get this point home. Cervical cancer is another big example that we can use here. We know that 37% of lesbian, gay, or bisexual women have been incorrectly told by a healthcare professional that they do not require cervical screening because of their sexual orientation.
That would be really nice if we didn't.
But we do, 37%. Yes. And we can take this concern even further. If we look at the low cervical screening rates amongst transmasculine patients, because they are low, who have retained their cervix. A recent 2021 study found multiple obstacles being faced by transmasculine non-binary people being able to access cervical screening. These included not receiving an invite due to the NHS not recording a person's transgender status on the patient record. That is called information erasure. It is the third biggest contributor to obstacles to trans healthcare. And other issues we were finding was samples being refused from the lab if the samples are marked as male. Again, information erasure. Now, this gives us serious food for thought about so many different things. But one of the things it really makes us consider is when we hear narratives such as only women have cervixes. And it asks us to consider, who does this narrative benefit? Because narratives such as only women have cervixes and similar organ gender-based narratives prevent practitioners from spotting diagnostic differentials such as cervical cancers, but also more common pathologies such as endometriosis.
So what we're discussing here has implications and considerations for LGBTQ plus patients, but there are also some considerations for our cisgender patients as well. And now this whole topic of only women have cervixes, there's also a lovely movement at the moment called In With the Bins, where they're trying to get sanitary bins in all toilets, not just in female toilets. And for the people who say, oh, we don't need, why would we need sanitary bins in male toilets? We do obviously have transmasculine patients who can still have periods, they still have sanitary products that they need to dispose of. But what about cisgender patients? What about your cisgender men who might have a stoma, for example, or who might be self-catheterizing for whatever reason? Where do they dispose of those products if not in a sanitary bin? At the moment, these cisgender males are having to use disabled toilets, which is massively disempowering as a patient to be led to believe that you have a disability because you have a stoma. But actually, that's one example of how these applications are relevant not only to LGBTQ plus patients, perhaps most importantly to them, but they do have applications for cisgender patients as well. So we're going to move on now to slide to myth 3. So the treatment we provide will be the same. I don't need to know how they identify. And these are all in quotes because these are the comments that we get from people, unfortunately. Now, in effect, in a nutshell, we've already answered this because we know that if their bodies are different, if we know that the differentials are different, we know already that we will have to make treatment adaptations as well. So in the same way, your treatment of somebody with arthritis will be different to somebody who doesn't have arthritis, anybody with surgical scarring or somebody who has long-term side effects from medications, we know your treatment for them cannot be the same. And this is it's an extrapolation of this same information. Even on a practical basis, if we are treating a trans female patient who is developing new breast tissue, new chest tissue, that will be enormously sensitive and they might be uncomfortable lying prone on our bench. Now, one important statistic that blows my mind every time I think of it, the US Transgender Survey, which was conducted in 2015, it's perhaps one of the largest surveys of transgender people that we have to look at, has about 27,000 responses. Of the respondents, 31% of them reported that they did not have a single healthcare provider who was aware that they are transgender. 31% of them. That's massive. So whilst we've been going through this talk, and you might be sitting there thinking, well, this is fine because I would know that this patient is transgender, so I would know to make that adaptation. You may not. And this highlights the importance of doing training like this, of being able to proudly say to your patients, I'm LGBTQ plus inclusive, I've done specific training on this, so that your patients know that you're a safe space, so that they can disclose to you that they are transgender, so that you can provide appropriate care. So it is absolutely vital to create safe spaces for our patients. So that trans female patient, for example, developing new chest tissue as an example of a treatment adaptation, it would be as simple as providing a pillow with cutouts so that she could lie comfortably prone on the bench so that I could provide care to her. Otherwise, she would be in discomfort throughout her treatment. She would be tensing up against me. It may inadvertently cause her further pain. It may impact my treatment outcomes. It may impact her outcomes from care, her satisfaction with the care provided. So it has a massive impact on the treatment that we provide.
So none of the stuff that we're talking about today is new. We already know that bodies are different, and we already accept the biopsychosocial model within healthcare. What we're asking for is the same acceptance that biopsychosocial model applies to LGBTQ people and particularly transgender people. When we start to remove people from the biopsychosocial model and not give them the same consideration, the same respect, we're getting into really dangerous territory, because we're not only not providing them with equal access to healthcare, but we're dehumanizing. And I want us to really recognize in this moment today that we live in a world whereby transgender people are being debated on TV, on the news. I'd just like to bring you back to that stat of 89% of transgender children considering suicide ideation, and pose that open thought about where that comes from. We live in a world where transgender people are being debated, attacked, and demonized. And we're sharing these photos as part of this myth from the AIDS pandemic in the 80s because we believe it is significant. We think it is really, really important that we recognize that this isn't the first time that the LGBTQ community has been demonized, and it's not the first time that it has impacted healthcare. We cannot allow this to happen again. When we were building the course, there were so many things that we came across which really struck us. And one of the things that's always really stuck with me is how the treatment of AIDS changed. How did we go from so many gay men being stigmatized for having AIDS, all those deaths, to where we are now? And what we found was that there was a nurse called Cliff Morrison, and Cliff Morrison worked in San Francisco, and he set up a ward just for gay men affected by AIDS. And it was the turning point. And there was lots of little things that he did differently, but to summarize down what he did is he allowed people and his patients to feel human. He took away visiting hours and he said, your people can come whenever you feel you need your people there. He took away next of kin. So he no longer said to people, who's your family? Because he recognized that for a lot of these people, they'd been ostracized by their family. So he allowed them to have simply their next of kin as their friends. And he encouraged touch between the nurses and the patients so that this idea of stigma, that they weren't worthy of healthcare, was taken away. It was so successful, it became known as the San Francisco model, and it revolutionized not only how we began to treat AIDS, but it is now the UN's #1 healthcare model when working with marginalized communities within healthcare. And the reason it's become that thing is because of how successful it is. When we destigmatize and allow people to feel human and respected in healthcare, we see health trajectories improving.
So people like to think of AIDS, of the AIDS crisis as something that's in the past. It's not. There is a legacy for lesbian women that we were the ones during the AIDS crisis who actually provided the care to the gay men because they could not receive healthcare because there was this stigma, because they were ostracized, because the care was refused to them. And so that is a legacy that for us as lesbian women, we carry forwards into today, as well as the trauma that is still in existence for many of these men, for many men who were subject to this treatment. Now, we do not yet know the impact of the COVID pandemic on the care that people are going to be receiving. We know that for gender identity clinics, the waiting lists are already stretching towards 5 years, and that's 5 years for them to just get their initial appointment. That's not to start treatment. So people are waiting 5 years before they're seen in a gender identity clinic. We began this seminar talking about an elderly man with HIV apologizing to Anna for her having to touch his body. We talked about my HIV positive male patient who was unable to talk because of fear of discrimination. This information is only in the past if we believe that it's in the past, and actually It's really not. This is very much part of our future. It's very much part of what we are carrying forwards. And what we do not want to see is this legacy of lesbian women caring for gay men, of the LGBTQ plus practitioners being the ones to care for the LGBTQ plus patients. We need to create a network of allies. That's why there is so much work being done nowadays. There's work by Stonewall, by Mermaids, work by Consortium, work by the LGBT Foundation. That's why it is so important that you as practitioners are undertaking training like this. It matters to us as a community. It matters to your LGBTQ plus patients and their families. It's only in the past if we believe that it's in the past, and actually there is still a huge amount to be done in terms of receiving equitable care for these patients. It is a nationally recognised health inequality. It's not a minority group complaining. So, Anna.
Earlier in the seminar, we shared a shocking statistic that 89% of transgender children contemplate suicide. That's children. That is nearly double the suicide ideation rate for non-transgender children. And for transgender people moving into their life, 41% of them will attempt to take their own life. 40% of trans people who had accessed or tried to access public healthcare services have reported having experienced at least one negative encounter because of their gender identity in the previous 12 months. And this experience is mirrored in studies which found that the #1 contributing factor to delays to transgender patients receiving healthcare was a lack of awareness amongst healthcare providers. Finally, a study into the life expectancy and health trajectories of LGBTQ people found that overall LGBTQ people's life expectancy to be shorter than their heterosexual and cisgender counterparts. There is such a gap in research for looking at health trajectories on LGBTQ people, but what that study did highlight and put forward as its recommendation is that unless there is more time and more effort spent on looking at examining the contributing factors, the inequality of health trajectories between LGBTQ people compared to cisgender and heterosexual people will widen. So this means that when we look at someone who's cisgender and heterosexual living on average 20 years longer than someone who is LGBTQ, it means that's going to widen and it's going to start to get bigger. And that's why it's so important, like Philippa says, that we're not only looking for other LGBTQ practitioners to support us, we're looking for allies, because if you're a healthcare practitioner and when faced with science, when faced with statistics, you look the other way, it's not the right place to be in for healthcare. There are people dying and struggling, and we need to wake up and we need to support those people.
So that leads us on to answer a lot of the questions that are coming up in the chat, which is, what do we do? How do we make these positive changes? How do I demonstrate inclusivity? What changes do I need to make? As you've probably gathered just from while we've been talking today, this is the type of topic that when we say LGBTQ plus inclusive healthcare, the response we get is, I treat all my patients the same. I don't need to know this. This isn't a topic. This isn't a thing. And hopefully from what you've seen today, there is so much more to this topic than first appears, than you first think about when you start looking into it. That's something that even Anna and I found as we've been developing, writing these seminars or writing these courses. There is more to it than even us as experienced queers, for want of a better word, would have thought when we first started looking into it. So the best way that we thought that we could get this information out there is to develop courses. We have developed 2 courses. We have one that is for clinicians, and we have one that's for non-clinicians. The reason for that is because we recognise that clinicians need to know the practical considerations for caring for LGBTQ plus patients. We need to know which nerves are involved in a phalloplasty. If somebody has a thigh flap phalloplasty, we need to know that they have taken the lateral femoral cutaneous nerve, just to give you a little sneak peek there. We need to know the impact of hormone therapies on the body, what that does to the muscles, what that does to the joints. We need to know about how to provide inclusive care from a trauma-informed perspective, the practicalities of gowning and robing LGBTQ plus patients, of asking sensitively about what surgeries they may have had. These are the things that we need to know as practitioners. then we recognise that there is a need for our non-clinical staff, so any administrative staff, any receptionists and things like that, who also need to be aware of inclusive care. This is important so that our LGBTQ plus patients aren't misgendered at reception, that there isn't any flustering or stuttering over what to say and how to support these patients, that people are aware of how to sensitively ask what pronouns a patient uses, what gender they might identify as. So there are two different streams of training in effect. So we have these two courses that are available to you. It's quite simply too big of a topic for us to do justice in these seminars, although we do try our level best. There is too much information out there. And we also wanted to empower people with practical information. So advice on your intake forms, on what those intake forms should look like, the changes that you can make, what you should be doing with your reception areas, what you can be doing with your website, what you can be doing with your marketing, how you can signpost to people that you are LGBTQ plus inclusive. So there is all that information and much, much more in these courses, including the legal considerations under the Equality Act, all of this information, which is stuff that you need to know. We are delighted to be able to offer you guys a £10 discount off the cost of the course as a thank you for giving up some of your time on a Saturday to come to see us. So we will make sure that you have that code. I will pop it in the chat as well so that you can use that. And what we're going to do now is just have a little look at some of the Q&As that are in there. So I know we've answered some of the questions live in terms of visual cues. A lot of these questions are too big of a topic, as we've said, for us to answer in a Q&A like this, because although there are little changes that can be made, there are bigger changes that you need to understand the context of before you put these changes in place. It's the same as why Pride Month is a bit of a bugbear for Rhiannon, because what we don't want to end up with is pride capitalism, where we're making these changes because we feel like we ought to and not because we know that it's the right thing to do. And we want to really encourage practitioners to walk the walk with inclusivity and to really align yourselves with that and recognise the importance of it. So we've got a personal question here from an anonymous attendee. I've recently found out my cousin is transitioning and has not spoken to their GP. They're getting drugs online to transition. How can I help them if they're refusing to speak to their GP? This is an enormous problem. Is it an entire lesson in the course that we wrote?
Entire module on black market
on the black market of accessing hormones and microdosing. This is why when we hear that 31% of people do not have a healthcare practitioner who is aware that they are transgender, you can access testosterone online, you can microdose. There is information on Reddit forums on how to do that, but that has such an important clinical impact. So in terms of that being something that we know is a problem, it is a massive problem. Anna, I don't know if you have any specific advice that you can offer to
so obviously we would always advocate for medical involvement from an endocrinologist in any form of hormone treatment. Obviously something we are recognizing, and in the course we do look at in great depth some of the safeguarding concerns around black market hormone treatments. What we would suggest is in that person's local area. For example, where I am in Brighton, there's a number of transgender charities, and it would be really wonderful if that person could make themselves known to a transgender charity. In Brighton, we have the Claire Project, we also have LGBT Switchboard, and we have a number of transgender side projects as part of bigger charities. Making themselves known to that charity so they can receive support. Quite often there will be medically trained professionals involved with those projects who can help advise and can ultimately help advise and mediate between that person and their GP so that they are respected, so that their legal rights are respected as well as a transgender patient. But yeah, definitely making themselves known to a transgender support project would be a really, really good first step, because then not only is it going to help try to alleviate some of the concerns around the hormone treatment, but it's also going to open them up to a community during a vulnerable time as well, which can only be a good thing.
So another question here from Lee, which I think is really important. What more can we do at a local level? Massive question. It is a massive question. In Somerset, we've introduced a few initiatives in respect of our LGBTQ plus communities, specifically around primary care and fertility, but I always feel that we can be doing more. This is something in my other roles and my other hats with the Rainbow Badges project. That was very camp of me, wasn't it? My other hat. But in my role, my other project is looking at things like the Rainbow Badges programme. I know at the moment that programme is oversubscribed. We've got 40 trusts who are signed up to it, but that would definitely be something to speak to your trust about whether you can get onto the next lot. If you're not, I don't have my map in front of me to know if Somerset is in the current tranche of LGBTQ+. In terms of at a local level, the importance is upskilling practitioners, so that when an LGBTQ+ patient, for example, walks into their GP, as we did, and said, hey, my wife wants to learn about whether we can induce lactation and do supplementary breastfeeding or chest feeding for our daughter, that we aren't met with blank expressions and not knowing what to do. So I think upskilling practitioners, the importance of doing specific training so that they know how to support these patients, because again, Anna will probably nod when I say this, but the feedback that we get from the case studies that we've done that are in the course, so you can hear from transgender people who have been kind enough to share their experiences with us, they have said that they feel that they have to educate everybody. You know, one of them, Ray, who is a transmasculine patient, he came in and during his talk, he said, I have to tell them what to do. I have to call up my GP surgery and tell them what to do. So the trans people are having to educate their healthcare providers. So actually being aware of the specific health issues, being aware of the intersectional issues, being aware of a trauma-informed model, being aware of signposting in the local area. So even creating a resource base of support networks for LGBTQ+ patients, of transgender specific care that's available, finding out what is available in your local area. There is a lot of information. It's a completely separate hat, but there's a lot of information that is out there on the consortium website, for example, in terms of member services that are available to people in your local area. But I think definitely spending some time with other people to find out what support is available, so that GPs can at the very least signpost to those in the area. So that would be that. Definitely, we are in talks with a lot of NHS, with Health Education England, and some other wider groups to roll this course out to them, and to roll both courses hopefully out to them, because it definitely is something that I think, in terms of being able to access training, and importantly being able to access training that you can come back to, is really important, because we recognise, much like these seminars, we tend to come in, there's a massive amount of information that we give to you guys in a very short space of time, and I'm conscious that there's like a minute left that we said that we were going to keep you, but we might hang on for a few minutes longer just so we can chin wag. But there is so much information that comes to you in these courses, and I think there's a temptation to then leave and think, I don't know where to start. And it's sometimes those small changes, but that's why, you know, I think being able to access courses, being able to access training where you can reflect, where you can come back to it, where you can make the next step and make the progressions, is so important to have that as a resource. The same as having access to people like myself and Anna, who really specialise in this sort of, you know, diversity, equity and inclusion training, so that you can come back to us with any questions that you might have. So Sarah, soft tissue therapist, hello there. Will you be running more of this workshop? You'd like to invite others to attend? We don't have anything planned at the moment. You can share the recording from today, that will be available. It is only going out to people who have attended the course, the same as the discount code. We're running until Monday, so you'll have that discount to sign up to the course until Monday. But absolutely, if you sign up to our list on our website, I think I've just posted it in the chat at oakleycoach.com/contact. If they aren't already on that mailing list, which is where we keep everybody informed of upcoming seminars, as well as on our socials, then you can invite them to come along to any future talks, as well as obviously they can enroll on the course at any point that they might want to. So I'm just going to have a little look in the chat as well, and obviously I'm conscious that it's now 2 o'clock, 3 o'clock, so anybody who needs to shoot off, then please do feel
I just wanted to jump on a question that I saw flag up that I jotted down. Someone asked about testosterone gel, and about how long it is live on the skin for. So we would say 24 hours. So for example, if I'm working on a patient and I know they've got testosterone gel on one of their shoulders, if it's in the last 24 hours, I can't touch that for my own safety. Otherwise, I would microdose on testosterone. But yeah, 24 hours. And again, what that comes back to is making people feel safe enough to share that information with you. And that's something that we go into a lot of detail in the course, the psychology of making people feel safe so that they feel comfortable, so that they can share information with you that is really clinically relevant for their safety and also for yours.
Brilliant. Is it the same if they're fully clothed, obs for adjusting and not massage, Anna?
No, so not the same for fully clothed. the testosterone gel can't contract through fabric. It literally has to be skin to skin contact.
And Vanessa, I don't know if you're still with us in health education at an undergraduate level. Absolutely, we can share the information. As we've said, you will have a recording that's available, so you can pass on these details to undergraduates. Rhiannon and I are very lucky. We have pre-existing links. We do some of our health coaching, motivational interviewing, communication skills training with institutions in the UK at an undergraduate level. We're hoping that some of them will take up this course as well, because actually I think, as with most of these things, if it's something that is incorporated into our training at an undergraduate level, it becomes a lot easier to then, you know, you have pre-existing awareness, as opposed to it being a new way of operating or new changes that you need to make.
Yeah. Ultimately, we want this to be taken as seriously as an area of healthcare as we take things like understanding prenatal care, how we understand arthritis. We believe this to be an integral part of healthcare in the 21st century.
Brilliant. Lovely. Well, everybody, just to summarise and just to say thank you all for attending. We will be sending out an email to you as soon as possible, as soon as we just tie everything up, as well as the link to the recording for this talk. So that you have this recording, so that you can come back and access this information. We are also going to be sending out a couple of resources to you that we've done just because, you know, we think there's so much information out there, which we hope that you'll find useful, where you'll also have your discount code to enroll on the course. As we said, that is available until Monday. So please keep an eye out on your inbox for that. And also the link to our private Facebook group, which we really hope you guys can join, because as we said, all three of us are in there. Rhiannon, myself and Anna are in there, and it is a safe space to ask these questions, as well as if you implement something and you have further questions, or you have a specific question about a patient or something that you want to ask. Obviously everything is anonymized within there. But that is a resource for you as well. So please, if you do have questions, we know that many of you will after this, because hopefully your heads have gone like ours did when we first started doing all of his training, that you will find that as a useful resource. And we really hope that you guys sign up to some of our courses and really take this forward. And thank you so much for all being allies of our community. Anna, is there anything that you wanted to say?
I'm just echoing all of that. Thank you, everyone. I'm seeing lots of thank yous coming through in the chat. Lots of people saying that it's been really informative. Someone say it's the best webinar they've listened to. So thank you so much. It's been really wonderful to put this together and for it to be so positively received. And like we said at the start, we think anyone working in healthcare believes in the power of human touch. So it's just wonderful to see that echoed back.
Thank you, guys. Sorry, Ella has just popped a question about safe binding practices. Yeah, again, covered in the course. Safe binding practices is a massive thing. So being able to advise your patients on that. So do pop in and have a little look. Okay.
That's okay, Ella.
so many questions about all of this, isn't there? There's lots of questions that come up. So yeah, do pop into the Facebook group. Now let me just I'll just access the link to the Facebook group so that you guys can pop in there. So if
there is any questions that due to time restrictions we've not been able to answer, I think we said earlier, Philip and I, that the email that will go out will have contact details. So if you wanted to get in touch to ask questions that aren't covered in the course, whether it be about the course in itself, the practicality of it, how it's delivered, or all of that stuff, then yeah, that will be in the follow-up email. So please do not worry if your question has not been answered.
Yeah, absolutely. We'll probably be lurking in the Facebook group for most of the rest of the afternoon. I've just popped a link to that in the chat, so do come in and ask any questions about the course or the content in there. So we will let you guys get on with the rest of your afternoon. So thank you all so much for attending. Thank you so much for your time. We're really glad that you found it so helpful, and we hope to see you all again very soon.
Take care. Bye-bye.
Bye. Bye.